Yeah, I'm sorry, but the video keeps like
Mm.
switching itself off, so I'll try my
Okay.
best. Anyway, here's me, and here's a picture. So, good afternoon, everyone. Thank you for joining me for the Peanut series, and I'm very thankful and honored to do the first of this year. So, in the next 45 minutes or so, we're going to talk about imaging of neonatal encephalopathy. Right, no disclosures. So the aim of my talk is we're going to go review what is neonatal encephalopathy. Then we're going to review the clinical aspects related to NE with a focus specifically on HIE or hypoxic ischemic encephalopathy. Then we're going to go through specifically the brief discussion of SANET grading and cooling and therapeutic measures used in HIE. And then we'll illustrate some of the imaging findings that we can see using ultrasound and MRI. So, neonatal encephalopathy describes the clinical syndrome of a newborn with any diffuse alteration of brain function with varying severity. It is a non-specific term, and the hallmark is altered mental status. It typically occurs within day of life, 0 to a few days after the birth, and it happens really in sort of typically in greater than equal to 35 weeks gestational age. So the signs and symptoms of neonatal encephalopathy manifests as poor breathing, altered level of consciousness, um, altered muscle tone, depressed reflexes, and seizures. There are many causes, and they include metabolic, infectious, drugs, trauma, tumor, and lack of blood flow or ischemia. But for the focus of this talk, we're going to go into more the ischemic aspects of HIE. And typically, the other causes can be distinguished using sort of history, physical exam, and multiple testing. So, neonatal encephalopathy that is caused by ischemia was historically known as perinatal asphyxia. It is an umbrella term and typically affects term infants. Um, it The American College of OB/GYN and American Association of Pediatrics endorses HIE for the ischemic reason when there is a clear evidence of an acute peripartum or intrapartum event. Now, HIE manifests in various ways, and it manifests in early postnatal life with abnormal fetal heart tracing, seizures, and low APGAR scores, which is defined as less than 5 at 10 minutes. Metabolic acidosis seen on blood gases, typically the umbilical blood gas with a pH of less than 7 or a base deficit greater than equal to 12. As we mentioned, seizure is very common. It's very common in infants with the other causes of HIE, um, as well as the ischemic cause. Now, the seizures can occur within hours to days of birth, and they can be either clinical or subclinical in nature. And they portend to basically adverse neurodevelopmental outcome. So, diagnosing these seizures is important. So, using the EEG to assess brain's electrical activity, that can help the clinicians in terms of defining subclinical seizures that may go undetected. Now, the extent of the injury from the seizure and the injury itself can be mild to severe slowing, and all this will help the seizure management in the present moment. However, EEG is also an important prognostic tool for subsequent brain injury and developmental outcomes in neonates, especially when after post-cooling. And we also know that the EEG, when it becomes normal or there's early recovery from a severe background abnormal changes or severe background activities within the first 24 to 36 hours, that can lead to that can sort of show the clinicians that this is a good prognosis for the future. Now, when is the timing of the event? It can be either prenatal, interpartum, or postnatal. And this is a very important question, and we'll try and tease that out subsequently. But I think history is a real key. History and the presence of a sentinel event. And then when you look at the history, you want to also think about the risk factors for HIE. So HIE is more common in moms with gestational diabetes, in the older moms of greater than 35 years of age, in the low birth weight babies. And these low birth weight babies also have an increased risk of the more moderate to severe HIE. And studies have found that males, for some reason, are more prone to this entity versus females. And if there is any evidence of meconium staining within the amniotic fluid, that is a major risk factor for birth asphyxia. Caesarean section has also been found to be an independent risk factor for HIE. Now, when we look at the causes, as I said, we can break it down. So we'll break it down, first of all, to the prenatal cause, which are as follows. So placental blood insufficiency, i.e. all related to vascular flow, preeclampsia, and again, maternal diabetes separately, but also if there's superimposed vascular insufficiencies, drugs and alcohol excess intake, severe fetal anemia, infections, congenital infections, whether it's overt or subclinical, again, can also happen, such as chorioamnionitis. And even though congenital abnormalities are an uncommon cause of HIE, they are also another cause of prenatal uh, um, cause of HIE. And with severe and they have these congenital abnormalities can have a high risk of fetal loss. So here is a case example of actually turned out to be trisomy 18, so the second most common aneuploidy after T21. And you can see on this coronal ultrasound image, there's agenesis of the corpus callosum, and here on the sagittal, here's the anterior posterior fossa. You can see that beautiful radial gyri pattern that you see with complete agenesis. Now, as you know, T18 is associated multi-system abnormalities with a high risk of fetal loss. They are also have a higher likelihood of low birth rate, weight rate, and therefore increases the risk of HIE. And in this particular baby, there's a tiny punctate foci of diffusion restriction here in the right frontal subcortical white matter. Next, we'll go on to the interpartum causes, which are well known about. So here's to list some few: uterine rupture, cord prolapse, abruption, but all these basically pertain to a sentinel event. And then I want to highlight again that history is key in sort of trying to parse out what the potential cause could be. And here, this is a baby, another case example. This was a late preterm, found to have congenital heart disease in utero, and they were induced for non-reassuring BPP. So in the maternal fetal medicine world, that's biophysical profile, which looks at the overall fetal health. So they went on to have a vaginal delivery and came out with very sort of poor APGARs and low tone. So in this case, as you can quite clearly see, there is diffusion restriction in the parenchyma. There is interparenchymal, intraventricular, and extraaxial hemorrhages. So these are sort of potential causes for HIE. Now, and then finally, in the immediate postpartum, um, there are mimics to the ischemic HIE, which we'll discuss here. The most common of which is vascular injury. So the most common vascular injury being arterial ischemic stroke. This diagnosis shares overlapping risk factors and also delivery room presentation with perinatal asphyxia or ischemic HIE. Arterial ischemic stroke, though, is less likely to have abnormal fetal heart tracing, and there may not be that central event that I mentioned in prior slides. So they want to think of like the poor fetal heart tracing, poor labor progression, things such as those nature. Again, infection comes up as another immediate postpartum cause as we go through the birth canal, or as the baby go through the birth canal. An additional risk factor for thrombosis is infection. And again, also metabolic and infective causes can present as HIE, but they typically present with sort of atypical clinical signs and symptoms. The SANART staging is used in the by our health providers or an adapted version of it, and it was first described back in the 1976. And basically, this helps describe the severity of encephalopathy. It is a classification system, and it is used clinically and graded into mild, moderate, severe, and it helps identify infants that require cooling, which we'll discuss on subsequent slides. Now, the clinical parameters that are used for SANART staging includes the mental status of the baby, the Suck's reflex, the Moro reflex, muscle tone, pupils. Again, here we see the seizures and the EEG also highlighted. So criteria for cooling. So therapeutic cooling or hypothermia is the standard of care for suspected HIE. The eligibility criteria for hypothermia are in general intentionally made broad to include any neonates who might benefit, as the benefit of cooling for potential HIE outweighs the risk of treating a neonate who is subsequently to have neonatal encephalopathy of a different cause. So what do they look for? So the general recommendation is gestational age greater than equal to 36 weeks. It should be done within 6 hours of life. And again, the sort of pH blood levels of less than 7 or a base excess of 16 and an APGAR of less than equal to 5 at 10 minutes. So again, these are the sort of also criteria to define neonatal encephalopathy. And then there's also the ongoing resuscitation at birth, as well as continuing for at least 10 minutes. So the criteria for cooling is really for that moderate to severe and encephalopathic babies. So that has been shown to have proven the most benefit and survival outcomes. And here, this is just to show you we have our own local criterias based on the generalized recommended criteria in the literature. So we try to stick to our criterias. But obviously, there's always a little bit of wiggle room. Again, we look for that sort of gestational age, and it's always that moderate to severe encephalopathy plus acidosis and the low APGAR and the significant resuscitation. Now, cooling comes in two different flavors or two different types, and it has been shown with trials that basically both types are equally effective, both whole body and head cooling. So the baby is cooled down to 33.5 degrees and cooled for 72 hours. And they are rewarmed slowly to prevent any complications such as hypotension. Um, since both techniques are equally effective, the majority of clinical preference is to use whole body, as there is greater ease of use, and it is also more cost effective than the head cooling. And the cooling is thought to reduce overall inflammation and cytotoxic edema, and it has been shown that it significantly decreased the mortality and morbidity, especially within by the age of like 6 to 7 years. And the cooling is better, earlier the better, and it should be done within the first 6 hours of life. Um, Sometimes they have cooled um, for slightly greater than that, but we try to stick to the 6 hour window. And in terms of imaging these infants, this basically outlines the general workflow. So I would say most places would typically start with an ultrasound, because as we know, the ultrasound is fast, easy, portable. These babies could potentially be unstable and very sick. Um, but we must be aware that there are limitations to the ultrasounds due to its low sensitivity, especially of acute ischemia. But we can detect sort of large hemorrhages, ventriculomegaly, and other more significant findings, which I will show you on subsequent slides. And then I would say, the your the main thing that people want to look at is really the MRI. So MRI will help obviously confirm the diagnosis. It'll help determine the extent of the injury, and it will define anatomically where the injury occurring. Um, and I would say there is variation in timing within your imaging, just depending on really sort of the local institution, um, availability, resources, and obviously the clinical status of the infant. It is also good used as a prognostic tool, just like the um, EEG tool, um, and um, it is typically performed within sort of day of life 2 to 14. If it's too early, i.e., within that first day of life 0 or 1, it can be falsely negative. Why? Because um, it's too early, and the changes have not occurred. So it's kind of good to check when that MRI was done. And then you can also add MRS. That also has some prognostic value, whether there's a presence of lactic peak or not. Again, that's a sign of abnormal metabolic activity and acute injury. Again, helping more of a confirmation and help guide management. You can also look for a low NAA peak, which is a sign for neuronal loss. Now, just as an added point, cooling does not affect the MRS in any way. So first off, ultrasound head findings. So I'd say most of the time it's normal. It's kind of normal. There's nothing, but you can see other findings, and we'll go through the sort of findings of increased echogenicity, and it has to be pretty extensive, as you can clearly see. Here's some more. So I hope this shows you. So this is a nice, good, normal um, baby in the same um, day of life 0, same as this child. And you can see that there is increased echogenicity in the central deep gray. What does increased echogenicity mean? It can be non-specific, um, if it's just a little bit focal, but in this case, it's much more extensive. So the differential then comes down to hemorrhage or ischemia. So this is most likely ischemic, whilst hemorrhage is more focal, and as you can quite clearly see, here on the posterior aspect of the corpus callosum in the splenium. And this was confirmed by a subsequent MRI in this baby. You can quite clearly see this on SWI, this hemorrhagic focus. And additional MRI changes, and especially with that case. So you can see diffuse cerebral edema. Here, there is pretty much extensive diffuse cerebral edema, as well as diffuse ischemia with loss of the cortical ribbon. So the cortex should be nice, gray, well-defined gyri that you should see, but this is quite extensive and diffuse. And even the central deep gray is all washed out here, you can see here. There's also sulcal effacement and very narrowed ventricles. And here's that hemorrhagic focus again. And then you see the same findings on the on ultrasound. So this baby ended up having multiple exams, and here you can see the sulcal effacement, the non-visualization of fissures, and that really severely narrowed ventricles. And here's a normal just for comparison. And there's that all that extensive diffuse parenchymal increased echogenicity here, both in the deep gray subcortical, deep white matter, very extensive bilateral. And this is what you're going to see on MRS also, that lactate peak at 1.3 parts per million ppm. So this is what we look for. Now, if there's a little peak just here, then it's very hard to determine whether is that baseline noise or is that really a lactate. So and then sort of more HIE cases. And we're going to talk more about the sort of patterns of injury now. So as I mentioned, the sentinel event is important, and that event at that event we need to know what the gestational age or maturity of the brain is at the time of the event, because that will help define the pattern that you see plus the extent of injury. Then you also want to know, how long was that degree of ischemia or hypoperfusion? Was it mild, moderate, severe, i.e., was it acutely profound versus partial, prolonged duration of ischemia? And then obviously the length and duration of that ischemia. And they all have an effect on the injury pattern. Um, and I would say, even though we have defined these injury patterns into nice, well-defined boxes, things don't fit quite well in these boxes. So these are kind of just recommendations, and nothing always quite fits the textbooks. And this is a heterogeneous entity. In order to understand some of this pattern that we're going to see, I also want to just quickly review what normal microvascular pattern is in the brain in both the preterm and the term baby. So in the preterm, they are still there is still an immature microvascular system. So there's an immature microvascular end zones and border zones. So we want to think of the vessels going towards the vascular zones as depicted by the blue. And then in the term baby, they are going away, away towards the cortex. So ventrifugal, therefore fugitive, running away. And why does that matter? So it matters because then you have in the preterm, we have more the ventripetal towards vascular pattern, while the term baby is ventrifugal, i.e. away. And this comes up in the imaging pattern. So here, this is the mild to moderate, the peripheral imaging pattern. And I think of HIE in two forms. So the mild, moderate together, and this is just a general outline versus so this is the partial prolonged, so i.e. mild to moderate asphyxia, versus the profound ischemia, just like complete closing of the tap, uh, and this leads to more a central pattern of injury. And then you want to then subsequent parcelate out whether they're a preterm or term. So in the term, even with the mild to moderate, you have that watershed zone pattern, the parasagittal zone pattern, and in the preterm, they're more likely to have that periventricular subcortical white matter, periventricular leukomalacia, and obviously the central severe in the preterm. There is that central gray pattern, but there is so in the preterm the central gray is all the areas of high metabolic demand, the thalami, plus also the brainstem, the cerebellum. And in the term babies, both the hippocampi as well as the uh, cortical spinal tracts are also involved much more. So we want to see images. Here, this is just a case of a day of life 0 full-term baby with respiratory failure and bradycardia. Um, and so we have axial DWI, axial ADC, T2, and T1. So here's some. So we know we can see the DWI changes, but I want to go through some of the changes that you'll see in T2 and T1. These are. So obviously we know that DWI is the most sensitive for acute ischemia. The DWI signal will peak at 3 to 5 days, and pseudo-normalization of that ADC map occurs around 6 to 8 days, maybe even 10 days. And cooling will prolong the DWI signal. So that hypothermia cooling alters the diffusion changes and prolongs it. And here, this is basically showing the diffusion restriction in the posterior limb of the internal capsule. So i.e., this is a central pattern of injury. You're also going to get loss of that normal T1 signal in the posterior limb of the internal capsule, as highlighted by these areas. So this is a case of HIE. So when you get a normal case, you want to start honing your eyes in for what normal looks like. So this is what it is, that nice T1 signal that is supposed to be there in a newborn or neonate. And why is that? That is where the cortical spinal tracts go through. And so when you're a baby, when you're born, you know, um, the the most important tracts are myelinated first, and so the baby wants to be able to move, so you have that cortical spinal tracts, and then the brainstem functions. And these are some of the changes that you'll also see on T2. So you got that mild decreased T2 signal here in the bilateral basal ganglia. There's also more increased T1 signal that you can see here. And again, these are the areas with the highest metabolic demand and associated with not just motor impairment, but this is also would be more of a moderate to severe grade in terms of HIE grading. And here is more imaging of the central pattern. And I want to show you guys that you can still see these changes. You can see the sort of, you know, continuing ADC reduced values at when in cooled babies. You can still see that diffuse pattern. And here on the ASL, there is diffuse decreased perfusion throughout. Um, and just briefly, I want to just go through. So we know what that central pattern look like here again. So we have diffusion restriction here in the bilateral posterior limb internal capsules. Um, there's also the T1 and T2 signal changes that are highlighted. You can also possibly see abnormal SWI signal with these increase linear SWI signal radiating out from the ependymal margins. And here's a very prominent vessel here. And this baby was called, and this is a severe encephalopathy on that Sarnat grading system. There's also significant seizures, and this baby had meconium aspiration with prolonged resuscitation and respiratory symptoms. So that central pattern, even though there is like just a small area of diffusion restriction, it takes it into that severe grading. And what does that mean from a clinical point of view? So what does that mean for our clinicians? So this is really important for our clinical colleagues because that helps them, gives them a framework to help them with their counseling for their family meeting, um, uh, just to give a framework. So, with that in that severe category, that means there's going to be sort of more likely to be more severe developmental outcome, especially with that deep gray pattern of injury. And this is very helpful for our clinicians, plus also for our families to get a sense of what the potential could be. Um, so I think this is a important aspect that we don't realize when we're reading these scans. And then here, post cooling, you see the diffusion restriction more or less sort of resolved. You get sort of the T1 signal in the posterior limb returning to some extent, and those SWI changes have more or less gone. So it was either sort of thrombosed vessel or very slow flow. Next, and then here's the watershed pattern that we're talking about. We're talking about that subcortical and the periventricular uh, white uh, white matter involvement. So on axial and coronal. So this was a term infant with placental abruption, and at that time, this was a very old case, but it's a day of life 4 with status post cool cap, and this would belong in that mild to moderate / partial prolonged asphyxia category. And I would say this is more, and this is just basically showing that, all these, there are overlaps, there are mix. So you can get a mixed pattern of injury where you have both the subcortical as well as the central gray involvement here. And again, here's that sort of diffuse loss of the cortical ribbon, also much more extensive. And then here, this is a case of cooling and showing that prolongation of the DWI signal. And then here, really, this is important from subsequent prognosis and follow up. There is severe cystic encephalomalacia, follow up at 9 weeks, with severe volume loss, diffusely bilateral, posterior predominance, subcortical, and this is the late sequelae of HIE. So I hope this has gone through briefly that, and some of the pearls I want to share is that history is key. There are other mimics to HIE that we should be aware of. They're very, very uncommon, but they are still present. And the clinical parameters such as hyper increased lactate, increased ammonia, they will point towards a metabolic entity, genetics, especially if there's other sort of other malformations or structural abnormalities, infection, and atypical clinical presentations as continuous refractory seizures or dysmorphic features are important features to try and elucidate from the medical history chart, and therapy to cooling should not be withheld when the cause of the encephalopathy is unknown, as the benefit of cooling outweighs the risk. Finally, I want to thank Peanut again for this invite. And lastly, I want to plug, we have a local event for any local trainees. We have our in-person RAD Expo on March 16th at 9 to 1. And this is a an event, a free event for medical students, trainees at all different levels to come and build community, network, meet other trainees from other programs, or if you want to get into radiology, bring a friend along. And that we've got great keynote speakers. Dr. Heller from RSNA is coming to be our um, keynote speaker. He's on the board of public relations and liaison, and he is also the CEO of RAD Partners. Plus, we're going to have education, fun and games, and breakout sessions, women in radiology, academic versus private, um, and we also have some a coffee bar for everyone to come and hang out and have some snacks. So with that, thank you again.
Thank you. That was great. If anybody has any questions or comments, feel free to put it in the question or the chat. And that event sounds wonderful too. It'd be great opportunity for trainees to get a great experience and meet everybody. And anyway, I just had a question. In your routine protocol, are you doing MR spectroscopy routinely in these cases?
Yes.
You are.
Yeah, we do. We do. Yeah, it's kind of part and parcel. It's standard, and we use single voxel for that. So we don't do the multivoxel acquisition. Um, and so we as for our institution, we are heavily connected with the labor and delivery um, women's hospital. So we we have we have we have that as part of our clinical workflow,
Mm-hmm.
as well as other centers, uh, sort of within the state. We use that, um, and also obviously then we also do see some of these cases, subsequently later down the line when they might present with like CP that has come to clinical notice, even as late as like 1 to 2 years. So CP, sorry, cerebral palsy. Oh, do we have any
Usha
chat
says that
in
was
this
awesome.
chat?
Thanks, Jessie.
Oh, thank you.
And are you doing ASL on all of these cases also?
No, not for the well, it's variable, I think. Like not at that
Mm-hmm.
women's hospital yet,
Mm-hmm.
but we have been revamping our protocols. So we have revamped the Lurie protocol, and we are including a lot more ASL, more not just in HIE but in other entities. And and yes, we will see that with the inpatient here. We haven't implemented that over at the our offsites. How about you guys? What do you guys do?
We started doing ASL in our neonatal protocols. We're trying to do it in more of the protocols as well, but it's definitely a work in progress to fine tune the imaging and make it
Yep.
useful, and also help with the prognostication.
Right. Oh, and then one thing I want to highlight to trainees also is that if there is no presence of lactate on the MRS, that does not exclude HIE, ischemic HIE. So I just want to, especially if they've been cooled also. So I spend quite a while like going through the notes with these cases.
Hmm.
It's kind of gold dust.
It just says they just dropped ASL from their neonatal brain protocol. So it seems like there's a certain number of ASL neonatal protocols. When one person adds it, the other person drops it.
Yeah, I know. I know. It's really tough because I wish there was like full coverage of the brain, honestly.
Hmm.
Like
Yeah, yeah,
uh and so I would because sometimes like, it's good if there's like a diffuse entity, but then you have to like then sometimes you could miss it if depending on where the area of abnormality is.
yeah, definitely. It's hard with the technique, and it's hard with these little babies because their necks are so short. So, yeah, an area to label that's appropriate, and yeah, there's a lot of
Right,
things
right,
that
right.
can go wrong with the ASL. So, making sure you're interpreting it correctly
Right.
in the appropriate setting, and making sure, yeah, within your um the technique at your institution, it's validated and stuff like that. So it's hard. But Usha said, yeah, they needed to make time for the MR spectroscopy. So that's true. We only have so much time, and
Yeah.
especially when we're imaging a lot of these babies, like with the feed and bundle technique, to try to image them as fast as possible while they're sleeping, and to not do
Right,
things
right,
that
right, right.
are too loud. Also, that would might wake them up.
Right. And then, we get quite a bit of like outside from other non-pediatric centers.
Hmm.
So they come and they may have already like started cooling, but then the imaging is, so that variable like MRI time frame is variable. It's very hard to stick depending on like when we get them or what events have been going on. Um,
Hmm.
I would say that case with that little like bilateral, two punctate foci of like basal ganglia diffusion restriction, it turns out like that baby was like very sick from like a whole host of other things like um respiratory um depression and wasn't wasn't that stable. So we don't realize what else is going on, plus the degree of like injury that just from the small areas that we see.
Yeah,
So
definitely.
very important. Very, yeah.
Yeah, and it's interesting. Yeah, I mean, we don't have one, but it's interesting. It'll be interesting to hear about the places that have those the scanners in the units, how they find that. Also, those the what's it called, them embrace or something. But so they don't have to transport the babies as much, and but
Oh yeah. Yeah. Um, yeah, so if it's inpatients, we scan them
hmm.
here on our
Hmm.
site, and then the women's hospital, they have their own scanner, so they'll scan there, and then when we have then we get it remotely.
Mm.
Um, so then we work with them for our protocol, but we don't have full control.
Yeah, yeah. It's always the it's always the difficult, yeah, when you're covering for so many different hospitals. Yeah, we have the same thing for some of our hospitals in town where the maternity wards are. Yeah, trying to
Yeah,
do quality control and making sure they're doing the right protocols can be challenging.
yeah, right. Um, And I would
Yeah,
say like most of the time we don't like here I think we don't really image the head ultrasound that much as because sometimes I don't know, it's a mixed bag with when we get these babies, really, quite honestly.
yeah. Any other questions or comments from the group?
Yeah, and well, last final
Yeah,
plug for all
sure.
those trainees, all those trainees. If you want to come, you can, there's a, just type in this on Google. And so it's a website registration. There's a free registration. And, just to let you guys know, this is a Saturday. The Sunday is St. Patty's event, St. Patty's day in Chicago. So come and see the Green River.
Are you giving out beers also, or what's the? Uh,
I wish, I
yeah.
wish. We might be giving out some free pens.
Oh, that's a good. Yeah. Sounds great.
No,
Well,
we're a small society. We're a small little like, small group, and so we're but any donations be happy.
awesome. Well, thank you so much, Jesse, for this wonderful talk. And this will be up on YouTube if anybody else that wants to watch or couldn't make it today. And take it, have look out for the ads for the next month's talk. And see you then. Thank you so much again. Have
Yeah,
a great.
thank you.
Take care.
Thanks.